My name is Linda Ingram, and at 32, I thought I'd seen everything working as a charge nurse in the psychiatric unit at Fairview General Medical Center in Westfield, Ohio. The fluorescent lights hummed their familiar tune down the sterile corridors, and the scent of industrial disinfectant had become as familiar as my morning coffee. After 8 years climbing from staff nurse to my current position, I believed I understood the delicate balance of trust that kept our unit functioning. Fairview General wasn't the largest hospital in Ohio, but our psychiatric wing had earned a reputation for compassionate care and strict confidentiality protocols. We served a community where everyone seemed to know everyone else's business, making our role as guardians of mental health privacy even more crucial. The weight of that responsibility never left my shoulders, especially during the evening shifts when the hospital felt like a small island of activity in the quiet Ohio countryside. The first sign something was wrong came on a Tuesday in late September. I was reviewing medication schedules when Erin Oliver, our unit supervisor, mentioned an unusual call from the state nursing board. Nothing specific, just routine questions about our documentation procedures. His weathered face showed the same concern I felt, but we both dismissed it as standard regulatory oversight. The second incident happened 3 days later. Kimberly Patterson, one of our most experienced staff nurses, pulled me aside near the medication room. Her voice carried an edge I'd never heard before, as she described a strange encounter with a patient's family member who seemed to know details about treatment that should have been confidential. We chalked it up to small-town gossip, but that lingered like smoke in the air. By October, the atmosphere in our unit had shifted in ways I couldn't quite articulate. Conversations seemed more guarded, and I noticed staff members glancing over their shoulders more frequently when accessing patient records on our Epic system. The usual camaraderie during shift changes felt strained, replaced by an undercurrent of suspicion that made my stomach clench. The agency nurse had been with us for 6 months by then, seamlessly integrating into our team with impressive credentials and an easy smile. They handled patient consent forms and privacy acknowledgments with the same meticulous attention to detail that had made them invaluable during our staffing shortage. Everyone trusted them, myself included, but trust, I was beginning to learn, could be the most dangerous thing in a hospital where secrets were currency and privacy was supposed to be sacred. The silence in our unit was growing heavier each day, and I couldn't shake the feeling that something fundamental had been broken. As I locked my office that Friday evening, watching the last rays of autumn sunlight fade through the reinforced windows, I had no idea that the foundation of everything I believed about professional integrity was about to crumble beneath my feet. The first real warning sign came during a routine staff meeting in November. Erin Oliver had called us together to discuss new HIPAA compliance protocols, his usual methodical approach to administrative updates. But as he outlined the changes, I noticed his eyes kept drifting to the agency nurse, sitting in the back row, taking notes with characteristic diligence. "We've had some concerns raised about information security," Erin said, his voice carefully neutral. "Nothing specific, but the administration wants us to review our procedures for handling sensitive patient data, particularly mental health records." The agency nurse's pen never stopped moving, but I caught a slight in their shoulders that hadn't been there moments before. It was subtle, the kind of micro-expression you learn to read after 15 years in healthcare, but it set off alarm bells in my mind. After the meeting, I found myself reviewing our recent cases more carefully. As Director of Patient Services, I had access to audit logs that tracked who accessed which records and when. The patterns I discovered made my coffee grow cold as I stared at my computer screen. The agency nurse had been accessing mental health records for patients who weren't under their direct care. Not frequently enough to trigger automatic alerts, but consistently enough to establish a pattern. Each access was technically within their scope of practice. They had legitimate reasons to review comprehensive patient histories, but something felt wrong. I decided to dig deeper, pulling up specific cases from the past month. Mrs. Henderson, a teacher at the local elementary school, had been treated for anxiety and depression following a difficult divorce. The agency nurse had accessed her records 3 times, including her psychiatric evaluation and medication history. 2 weeks later, I'd heard through the hospital grapevine that Mrs. Henderson had been placed on administrative leave pending a, quote, fitness for duty evaluation. Then there was Marcus Thompson, a college sophomore who'd been hospitalized for a panic attack during finals week. His records showed a history of anxiety medication and counseling sessions. The agency nurse had reviewed his file extensively, including notes from our psychiatric consultation service. Within days of his discharge, Marcus had been called before his university's academic review board to discuss his mental health status and its impact on his scholarship eligibility. The coincidences were piling up like autumn leaves, and I couldn't ignore them anymore. I started paying closer attention to the agency nurses' daily routines. They arrived early, stayed late, and seemed to have an unusual interest in our filing systems. During lunch breaks, I noticed them spending time in the records room, always with a plausible explanation, updating charts, filing discharge summaries, organizing consent forms. But it was their interaction with technology that really caught my attention. The agency nurse was remarkably skilled with our Epic system, navigating between modules with an efficiency that impressed even our IT department. They'd volunteered to help streamline our documentation processes, offering to handle the more complex privacy acknowledgments and consent procedures that other staff found tedious. "They're a godsend," Kimberly Patterson had told me just weeks earlier. "Finally, someone who understands how to make these systems work for us instead of against us." Now, watching the agency nurse's fingers fly across the keyboard with practiced ease, I wondered if that expertise was being used for purposes we'd never intended. The breakthrough came on a Wednesday evening in late November. I was working late, catching up on quarterly reports, when I noticed the agency nurse's workstation was still logged in despite their shift having ended hours earlier. The screen showed our patient portal system, but not the usual nursing documentation interface. Instead, they'd been accessing the psychiatric services database, specifically the section containing detailed mental health assessments and treatment plans. My hands trembled as I took screenshots of the screen, documenting the unauthorized access. The timestamp showed the agency nurse had been in the system for over an hour after their official shift ended, systematically reviewing files for patients across multiple departments. I spent the next few days conducting my own investigation, cross-referencing the agency nurse's access logs with subsequent events in our patients' lives. The pattern became undeniable. Patient after patient who'd received mental health treatment at our facility was facing unexpected scrutiny from employers, schools, or licensing boards. Information that should have been protected by doctor-patient privilege was somehow finding its way into the wrong hands. The most damning came when I discovered a series of encrypted files on a shared network drive that the agency nurse had created. Using my administrative access, I was able to decrypt several documents that contained detailed summaries of patient mental health information, formatted in a way that suggested they were being prepared for external distribution. One file contained a comprehensive report on Sarah Mitchell, a nurse practitioner who'd sought treatment for postpartum depression. The document included her medication history, therapy notes, and even personal details from her counseling sessions. 3 days after this file was created, Sarah received a letter from the state nursing board questioning her fitness to practice and demanding a comprehensive mental health evaluation. Another file detailed the case of James Rodriguez, a police officer who'd been treated for PTSD following a traumatic incident. The report included sensitive information about his triggers, coping mechanisms, and medication regimen. Within a week, James was placed on administrative leave pending a psychological fitness assessment that seemed to mirror the details in the leaked file. The scope of the betrayal was staggering. Dozens of patients, all trusting our facility with their most vulnerable moments, had been systematically violated. Their private struggles with mental health were being weaponized against them in their professional lives, turning our hospital into an unwitting accomplice in their persecution. I realized I needed help, but I wasn't sure who to trust. The agency nurse had cultivated relationships throughout the hospital, earning respect and admiration from colleagues who had no idea about their true activities. Bringing accusations without ironclad proof could backfire spectacularly, potentially destroying my own career while allowing the real perpetrator to escape justice. That's when I decided to approach Kimberly Patterson. Despite her initial praise for the agency nurse, I'd noticed her growing more reserved in recent weeks. During our conversation in the break room, I carefully probed her observations without revealing my suspicions. "Have you noticed anything unusual about patient confidentiality lately?" I asked, keeping my tone casual. Kimberly's expression darkened. "Actually, yes. I've had 3 families ask me how their employers found out about their treatment here. I thought it was just coincidence, but now that you mention it." I showed her some of the I'd gathered, watching her face grow pale as the implications became clear. The agency nurse she'd once praised as a godsend had been systematically betraying the trust of every patient who walked through our doors. "We have to stop this," Kimberly said, her voice barely above a whisper. "These people trusted us with their lives, their futures. How many careers have been destroyed? How many people are suffering because of what's happening here?" Together, we began building a comprehensive case against the agency nurse. We documented every suspicious access, every coincidental timing between record reviews and subsequent professional consequences for patients. The Gracker was overwhelming, but we knew we needed to be careful about how we proceeded. The agency nurse was smart, careful, and had covered their tracks well. They'd exploited legitimate access to patient records, using their position of trust to harvest sensitive information that could be sold or traded to employers, schools, and licensing boards. It was a sophisticated operation that had been running under our noses for months. As we prepared to take our to Aaron Oliver and the hospital administration, I couldn't help but think about all the patients whose lives had been irreparably damaged. Teachers forced out of their jobs, students losing scholarships, healthcare workers facing license revocation, all because someone they trusted had betrayed that trust in the most fundamental way possible. The agency nurse's betrayal wasn't just a violation of HIPAA regulations or hospital policy. It was an assault on the very foundation of healthcare, the sacred trust between patient and provider that makes healing possible. They had turned our hospital into a weapon against the people we'd sworn to help. The next morning, Kimberly and I requested an urgent meeting with Aaron Oliver, our chief medical officer. His office felt smaller than usual as we spread our documentation across his mahogany desk. Printouts of access logs, patient complaint summaries, and a timeline that painted a damning picture of systematic privacy violations. Aaron's expression grew increasingly grave as he reviewed our shitey. "This is extensive," he said finally, removing his glasses to rub his temples. "You're alleging that an agency nurse has been selling patient mental health information to third parties?" "The pattern is undeniable," I replied, pointing to our timeline. Every patient who's complained about unexpected professional consequences had their records accessed by the same person within 48 hours of their treatment. The timing isn't coincidental. Aaron leaned back in his chair, the weight of the situation settling over him. "If this is true, we're looking at massive HIPAA violations, potential criminal charges, and lawsuits that could cripple this hospital." "Are you absolutely certain about these allegations?" Kimberly spoke up, her voice steady despite the tremor in her hands. "I've personally spoken with 7 families. Their stories are identical. Confidential mental health treatment, followed by immediate professional retaliation. Someone is feeding information to employers and schools. I need to involve legal counsel immediately," Aaron said, reaching for his phone. "This stays between us until we determine how to proceed. Not a word to anyone else on staff." The investigation that followed was swift but thorough. Hospital security reviewed badge access logs while our legal team worked with IT to trace digital footprints. Within 72 hours, they'd uncovered a sophisticated network of information trafficking that extended far beyond our initial suspicions. The agency nurse had been using their legitimate access to patient records to compile detailed dossiers on individuals seeking mental health treatment. These files were then sold to a network of private investigators and background check companies who marketed the information to employers, schools, and licensing boards under the guise of, quote, comprehensive screening services. When confronted with the O's, the agency nurse initially denied everything, claiming the access patterns were coincidental and related to legitimate patient care duties. But when presented with bank records showing regular deposits from shell companies linked to the information brokers, their facade crumbled. "You don't understand the pressure I was under," they said during the formal interview, tears streaming down their face. "I have student loans, medical bills for my mother. These people offered me more money in a month than I make in 6 months here." The confession was devastating in its scope. Over 18 months, they'd compromised the privacy of nearly 200 patients, selling detailed mental health information that had destroyed careers, ended educational opportunities, and shattered lives. Teachers had lost their jobs, students had been expelled, healthcare workers had faced license revocation, all based on confidential treatment records that should never have left our hospital. Aaron worked closely with state regulators and federal investigators to ensure full compliance with reporting requirements. The Ohio Department of Health launched their own investigation, while the FBI opened a case into the interstate trafficking of protected health information. The agency nurse was immediately terminated and escorted from the premises by security. Their nursing license was suspended pending investigation, and criminal charges were filed within the week. The agency that had placed them faced scrutiny as well, with questions raised about their screening processes and oversight of contracted staff. But the damage extended far beyond one individual's misconduct. Patient trust in our hospital plummeted as news of the breach spread through the community. Families who had sought help for depression, anxiety, and other mental health conditions now faced the terrifying reality that their most private struggles had been commodified and sold. The legal ramifications were staggering. Class action lawsuits were filed on behalf of affected patients, seeking damages for lost employment, educational opportunities, and emotional distress. Our malpractice insurance carriers launched their own investigations, and the hospital faced potential fines from multiple regulatory agencies. Throughout the crisis, Kimberly remained my strongest ally. She worked tirelessly to contact affected families, offering support and resources while helping coordinate the hospital's response efforts. Her dedication to making things right, even when it meant working unpaid overtime and facing angry confrontations from betrayed patients, demonstrated the kind of integrity that made healthcare meaningful. "We can't undo what happened," she told me one evening as we finished updating patient notification letters, "but we can make sure it never happens again. These people deserved better from us." The investigation revealed systemic weaknesses in our privacy protections that had made the breach possible. Inadequate monitoring of record access, insufficient background checks for agency staff, and outdated audit procedures had created an environment where patient information could be harvested without detection. Erin implemented immediate reforms, including real-time monitoring of all record access, mandatory privacy training for all staff, and enhanced screening procedures for temporary personnel. The changes were comprehensive but necessary, designed to rebuild the trust that had been so catastrophically violated. As the weeks passed, the full scope of the betrayal became clear. The agency nurse hadn't just stolen information, they'd weaponized our commitment to healing, turning our hospital into an instrument of professional destruction for the very people who'd sought our help. The silence in the psychiatric unit was different now, heavy with the knowledge of what had been lost. Patients who once spoke freely about their struggles now hesitated, wondering if their words would somehow be used against them. The sacred space of healing had been contaminated by greed and betrayal. 12 months later, I stood in the training room at Regional Medical Center in Columbus, watching a group of newly hired nurses take notes as I explained the importance of social media privacy policies. The irony wasn't lost on me. My greatest professional failure had become my most meaningful contribution to healthcare. Patient information exists in many forms, I told the group, clicking to the next slide. Text messages, social media posts, casual conversations in elevators. Every piece of data we encounter belongs to someone who trusted us with their most vulnerable moments. The faces looking back at me were young, eager, untainted by the cynicism that had nearly consumed me after the breach at Fairview General. I train healthcare workers on social media privacy policies now, traveling between hospitals across Ohio to share hard-learned lessons about digital security and professional ethics. The settlement with affected families had been substantial but necessary. Fairview General had implemented every recommended reform, transforming their privacy protocols into a model that other hospitals now studied. Aaron Oliver had been promoted to Chief Medical Officer, his leadership during the crisis earning recognition throughout the healthcare community. Kimberly Oliver had followed me to Regional Medical, accepting a position in our Quality Assurance Department. Her dedication to patient advocacy had only strengthened after witnessing the devastating impact of privacy violations. We worked together now, developing training programs that emphasized both technical security measures and the human cost of betrayal. The agency nurse had faced criminal charges for identity theft and fraud, receiving a 2-year prison sentence and permanent exclusion from healthcare employment. Their nursing license had been revoked in all 50 states, ensuring they could never again exploit the trust placed in healthcare professionals. But the real victory wasn't in punishment. It was in prevention. Every hospital that implemented our training protocols represented hundreds of patients whose privacy would remain protected, whose trust in the healthcare system would remain intact. During my lunch break, I often walked through Regional Medical's psychiatric unit, observing the quiet conversations between patients and staff. The atmosphere here felt different from those final months at Fairview. Lighter, unmarked by the weight of betrayal. Patients spoke freely about their struggles, confident that their words would remain within these walls. My phone buzzed with a text from Kimberly. Great feedback from this morning's session. The nursing supervisors want to schedule follow-up training for their entire staff. I smiled, remembering how isolated I'd felt during those dark weeks when the breach first came to light. Now surrounded by colleagues who shared my commitment to patient privacy, I'd found a sense of purpose that transcended the trauma of the past. The evening sun streamed through the training room windows as I packed up my materials. Tomorrow would bring another group of healthcare workers, another opportunity to share the lessons learned from our collective failure and recovery. As I walked to my car, I thought about the patients whose lives had been disrupted by one person's greed and betrayal. Their courage in coming, their willingness to trust the healthcare system again despite being so profoundly violated, had inspired every reform we'd implemented. The parking lot was quiet, the day shift giving way to evening coverage. In hospitals across the state, nurses were accessing patient records with enhanced security protocols, their every keystroke monitored and protected by systems designed to prevent another breach. It was finally over, and the silence felt earned.